Hi, everybody. So today we're going to go ahead and go over the neuropsychological aspects of some of the psychiatric or psychological conditions. So these are the conditions you would typically study in abnormal psychology. And they all have brain-based things that are related. So we'll start with schizophrenia. DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. So we abbreviate it DSM. And so the symptom list here is accurate. So you have delusions, which are fixed false beliefs about reality. You have hallucinations, which are sensing things through one of your 5 senses that aren't actually there. So seeing things, hearing things, smelling things, tasting things, feeling things that are not there. Disorganized speech, lots of different ways this can go. You can be tangential. You can, as they mentioned here, have senseless rhyming. We call that clang association. You can only repeat what people say, and sometimes you can't talk at all. And disorganized or agitated behavior is also a component here as well. So sometimes they'll just be really on edge, jittery. Other times they'll sort of hold these odd poses and they're almost like a wax figure. You can mold them. Very odd. There are also other symptoms the person can experience. Lots of different structural abnormalities have been found in the brains of those with schizophrenia. So they weigh less. The ventricles, those fluid-filled portions, are bigger. There are fewer neurons in the prefrontal cortex right up here, thinner in some places. They have abnormal cellular structures some places. Hypofrontality means they really struggle with something like card sorting. They can't make those changes you have to on a card sorting task. They also have found that there are differences in the organization of neurons. So A would be a typical person's neurons, and then you can see B, where they are not all lined up, kind of a little bit willy-nilly, which is, I think, unfortunately a nice metaphor for a lot of what life feels like to people with schizophrenia. These are some of the biochemical changes, so neurotransmitter-related changes. Dopamine is implicated. Glutamate is implicated. GABA is a huge one that is implicated here. Lots of different things going on. Now, some people have argued that schizophrenia might actually be a neurodevelopmental disorder. It tends to begin in late adolescence or early adulthood. So 20s to early 30s is when we typically see what is called a psychotic break, when the person has their first psychotic symptoms. There's a slow emergence of these brain abnormalities during adolescence, and it's a combination of genetics and the environment. So there's no single gene implicated. However, recent research has suggested that schizophrenia, what we call schizophrenia, might actually be several different genetic disorders. And so we might actually have a label on something that's several somethings. So we're still really figuring this out. And there's a lot of people who have adverse events either prenatally or after they're born. Now, in terms of what happens when you give someone with schizophrenia neuropsychological assessments, not great, basically, unfortunately. They have problems with working memory, episodic memory, language, executive function, attention, and sensory processing. They think a lot of this is related to those prefrontal cortex issues, but obviously very problematic. Okay, so the next thing we'll talk about are the mood disorders, and the mood disorders are really the most common of any of these disorders. So depression in particular tends to affect about 12% of the population to 15% of the population lifetime. So it's something very common, unfortunately. This is sort of a really abbreviated list of symptoms for depression, so I'm going to go into more depth for y'all here. So a major clinical depression, or major depressive disorder as it's labeled in the DSM, is marked by having at least one major depressive episode. And a major depressive episode has to last for at least 2 weeks with, I believe it is 5 or more of the following symptoms. And you have to have that every day for that 2-week period. Most people with depression, it's much longer, unfortunately. So you feel depressed most of the day. You have less interest or pleasure in engaging in activities you usually enjoy. You have appetite changes, so you might gain or lose weight as a result of this. You have insomnia, not able to sleep, or hypersomnia, sleeping all the time. You have psychomotor agitation, which is like being on edge, bouncing, wound up, or psychomotor retardation, which means everything slows down. So this is the word retard, like we use it in music, for example, means to slow down. When I was treating clients, I never saw anyone with psychomotor agitation. With depression, they always had the slowing down. And then you have fatigue or loss of energy. You have feelings of worthlessness and guilt that they mention here. And then you have diminished ability to think or concentrate is actually one of the symptoms. So clearly we're going to see some neuropsychological issues as a result of depression. And then you have recurrent thoughts of death, recurrent suicidal ideation with or without a specific plan, or suicide attempt. And obviously this is the most severe symptom, the symptom we worry about the most. And you don't have to have that symptom to have depression, but those with severe depression unfortunately typically experience this. So mania is the opposite in terms of mood from depression. Again, a manic episode is how you define someone as having experienced mania. And a manic episode consists of 1 week of persistently high, expansive, or irritable mood. And then you have to have 3 of the following: grandiose self-esteem, so feeling like I'm the best there is, feeling like you need less sleep than usual, being overly talkative, partially to keep up with the next symptom, which is your racing thoughts, easily distracted, again, you're going to see this come on a neuropsychological test, increased activity or agitation, and engaging in high-risk activities, for example, engaging in sexual conduct without condom use, drinking and driving, things along this line. So in order to be diagnosed with bipolar disorder, you have to have at least 1 episode of mania or manic episode for bipolar 1 disorder. There's also a bipolar 2, where you have what's called a hypomanic episode, just a shorter, less severe manic episode. And then with bipolar disorder, you'll also see episodes of depression, and that's where we get the name bipolar, because they swing from these high highs of mania down to these low lows of depression. Now, there's a lot of neurochemical aspects of depression. Depression is probably the disorder we have the most research about with this, mostly because, again, it's so common, unfortunately. So monoamines are a problem here. Brain-derived neurotropic factors, or BDNF. These are related to stress. If you give a person antidepressant medication, it helps to regulate these. And in fact, some of these may relate to the problem with monoamines. The HPA axis is really what's implicated here, the hypothalamic pituitary adrenal axis. So what happens here is when you have chronic stress, you have something like depression, you have a lot of cortisol that's secreted. That's going to influence your cerebral functioning in general and cause problems in your hippocampus. So that's where you get some of those memory problems. So this shows you that HPA axis. So there is a shutdown that is faulty in depression. So it doesn't shut down. And so there's this like feedback loop where it just keeps going. And so you end up with lots of issues. HPA axis is also implemented in anxiety disorders, similarly. Other neurotransmitters implicated in depression include serotonin and dopamine, and many of the antidepressants actually target those specifically. Now, in terms of neuropathological and blood flow abnormalities, you see decreased activity in some of the prefrontal regions. That's where you get some memory and attention problems. But you have increased activity in areas that you don't want increased activity in. So orbital regions, they're trying to inhibit amygdala activity. They're trying to break those persistent negative thoughts. That's one of the things that really research has shown is perpetuated depression, is the idea that you will have these negative thoughts about yourself and the world. The amygdala is overactive, and that's going to just cause the HPA axis to be overactive, and also your medial thalamus. So if you do MRI studies or you do autopsies after someone with depression passes away, you show abnormalities in the orbitofrontal cortex and the hippocampus for both people with depression and bipolar disorder. Now, one of the really interesting things your book doesn't touch on that recent things have been starting to show is, in addition to medication, talk therapy, in particular cognitive behavioral therapy for depression, actually creates changes in some of these areas of the brain. So as you get better, your brain also gets better, which is really interesting and fascinating. All right, so in terms of bipolar disorder, you have less brain matter in the temporal lobe and cerebellum. And the more episodes you've had, both manic and depressive, the more of a decrease you have. There's what's called the sensitization model, where there are large individual differences in degree of sensitization and drug effects for both lab animals and people. Abusing stimulants like cocaine is associated with manic episodes. And bipolar individuals in general, because of the pathology, are at high risk for substance abuse, and so they're often recurring. As I mentioned, anxiety disorders are also related to that HPA axis. Anxiety disorders are also quite common. One thing I have to say, I walked you through this list here. This is a little out of date. So in the DSM-5, panic disorder, generalized anxiety disorder, and phobias are all classified as anxiety disorders. But now post-traumatic stress disorder is now under a stress-related disorders category, and then there's now a separate obsessive compulsive and related disorders category. So even though those have components of anxiety, the DSM-5 recognizes that they have more than just anxiety as pieces of them and have created their own categories for them. But the common thread, as this points out, is fear through all of this. Really, this is an overactivation of your fight or flight system when you don't actually need to have it activated because you're not in a life-threatening situation. So drug therapy is what they're calling anxiolytics, anti-anxiety medications. Interestingly, a lot of these are also antidepressants. So things like the SSRIs that are antidepressants also work for anxiety, partially because, again, the same parts of the brain seem to be implicated. One of the ways to treat phobias in particular, but also some other aspects of these other disorders, is what's called systematic desensitization. So if you're afraid of some specific object or animal in this case, you have the person create a fear hierarchy. Like, what's the scariest thing I can imagine with that? Which I'm guessing this is probably pretty high for this person with the spider on your hand, right? And what's the least scary? And then you work up it. So you might start with like the spider in the cage on the other side of the room, and the person's like at the door looking in, and that's all they can do that day. You teach them relaxation techniques like deep breathing and relaxation, muscle relaxation, and you have them work up to actually being able to interact with their feared stimulus. And again, that's showing some changes in the brain as well. Very cool. I like this slide just because I think it highlights in general the importance of the mind-body connection. So we know that if something's going on in your brain or in your body, it affects the other and vice versa. So a lot of times with this whole field called health psychology that focuses on this, a lot of times your recovery from some sort of illness can be better if you focus on any psychological issues that are going on. So they're talking about cerebrovascular disease, so patients with stroke, where it's directly affected the brain. And here you see up to half of them experience depression, about a quarter have generalized anxiety disorder. They might have odd affect or fearfulness, almost like PTSD as a result of it. Now, this we would expect because it's in the brain, but we see a lot of these same things in people who have had heart attacks, for example. So there's some really interesting studies where they have People who are recovering from stroke or heart attack engage in therapy, relaxation, meditation, and not only does it help them physically, but or help them mentally, but it also helps physically. So things like their blood pressure goes down. Now there's psychosurgery. So this is actually operating on the brain, and the way you do it in psychosurgery is you destroy a region of the brain to alleviate psychiatric symptoms. So if we think back to HM and how they took out parts of his brain to try to help his seizures, right, that's psychosurgery. Neurosurgery is kind of the opposite. So neurosurgery is where you want to repair damage and alleviate symptoms that way. So Egas Moines in 1935 was the first to do that prefrontal lobotomy. There are some graphic, disturbing, but important videos on YouTube that I've linked for you all on this. I really recommend that you watch them, even though it's hard. If you're squeamish, just heads up, they talk about how they inserted the, what were literally ice picks to do this, right? So a prefrontal lobotomy, essentially they just put a sharp stick up and mashed around your brain, and then patients were calmer, and it was because you messed with the prefrontal cortex, which controls things like personality and emotion, right? So they did this to hundreds of thousands of patients, and they didn't really know what they were doing. They went in blind and just sort of did this. Ethically, we would not allow this to occur today. So modern psychosurgery has 13 specific targets. There's a slide next that'll show you those targets. You have very small lesions that are carefully planned. And also, we don't do psychosurgery that often. This is sort of the last resort. We're going to try medication, therapy, anything we can to avoid cutting into someone's brain if we don't have to, right? After the abnormal activity is removed, it's not replaced with normal activity. So that's another reason why we're hesitant to just do this. So here you see those targets that we will address with psychosurgery, and again, rarely. So again, just a quick overview of some of the psychiatric stuff. Hopefully you found this interesting, and this is, I'm a clinical psychologist, so this is something I'm passionate about.